Right. Well, hello, everyone. My name is Diaz Chilori, and I'm the current president of UCLA Anderson's Healthcare Business Association. I'm very excited to welcome you all to the ninth annual Vitals Conference, where we will be exploring a variety of topics centered around precision medicine. And of course, a big thank you to all of our Vitals team. We have a team of really um, diverse and passionate healthcare MBA students and who worked really hard to put together this conference. So to start off, it's my pleasure to introduce our dean. Dean Antonio Bernardo is the ninth dean of UCLA Anderson School of Management, and he holds the John E. Anderson Chair in Management. He became dean on July 1st, 2019, and joined the Anderson faculty in 1994, where he became a professor of management in the finance area. He has a long history as an active, engaged member of Anderson's faculty and administration, having served as department chair and senior associate dean for academic affairs, and twice as the finance area chair. And he's taught over more than 5,000 students during his time at Anderson and has earned many teaching and leadership awards. He's also taught internationally at the Fudan University in Shanghai, China, and at the India School of Business in Hyderabad, and also has held a visiting appointment at the University of Chicago. He's published many articles in finance, econ, and law journals, and served as the associate editor of several of those journals. Born and raised in Canada, Dean Bernardo earned his bachelor's degree in econ from the University of Western Ontario and his doctorate in economics from Stanford University. So for our opening remarks, please welcome Dean Tony Bernardo.
Thanks, Diraj. Good morning, everyone. Welcome to the UCLA Anderson Healthcare Conference, also known as Vitals, which is organized and sponsored by Anderson's Healthcare Business Association. This is always a great conference on one of the most important subjects of the day. This year's conference theme is the pursuit of precision medicine, and you'll be hearing from a number of terrific speakers on issues related to that topic, including from this morning's keynote speaker, Dr. Marc Williams. The Vitals Conference has become a tradition at Anderson, and I'm proud of our students for creating and organizing this event, and for recognizing the need for better information and for deeper connections between healthcare and business. It's clear that innovative leaders with management training, like our Anderson MBAs, are vital to finding solutions to the critically important questions facing the healthcare industry here in our country and around the world. That's exactly why Anderson and our students are involved. We have only to look at some of the biggest headlines of recent years, from the COVID pandemic to the continuing inequities in healthcare in our country, to understand just how important these topics are. Here at Anderson, we're lucky to have excellent professional schools with wonderful expertise and great research related to healthcare, not just the medical and dental schools, but the schools of public health, nursing, life sciences, and engineering. These professional schools are our partners in some of the innovative interdisciplinary work that occurs on this campus and helps create progress on the toughest health policy and cost challenges affecting the United States. Throughout the day, you'll hear from outstanding keynote speakers and from panelists talking about issues related to precision medicine. They'll be addressing such topics as precision pharma, the precise and careful use of patient data, and how to make the care delivery model known as value-based care work. Healthcare today overlaps more and more with such sectors as technology, finance, engineering, and many more, and there's no question about the growing importance of the industry to the local and California economy. Given how absolutely vital health and healthcare is to an individual's quality of life, to employment, and for the health of our economy, it's not surprising that many students arrive at our campus with interests in healthcare and related fields. Our students include doctors, dentists, consultants, and life science and healthcare professionals interested in bringing business and good management practices into their careers. We also have numerous alumni working in the medical device field, as well as founders and chief business officers of early-stage biotech companies. And there are many alumni who work for health insurance providers and hospital systems, seeking to provide quality care in their communities regardless of ability to pay. That commitment to service and social impact is part of the DNA of Anderson, too. You'll be hearing about healthcare at Anderson as we continue to expand our course offerings, and UCLA Biodesign, a program to promote the development of healthcare innovation at UCLA and translate those concepts into commercial opportunities through collaborations with the schools of medicine, engineering, and others. There's so much to be excited about when it comes to healthcare at Anderson, and it's an area that we're very much committed to. I'd also like to recognize and thank Johnson & Johnson for their sponsorship of this event, which is essential in making the conference possible. And of course, thanks to the Healthcare Business Association, especially HBA President Diraj Jaluri and the conference co-chairs for their work in organizing it. Thank you very much and enjoy the sessions. Diraj?
Thanks, Dean Bernardo. It's my pleasure to welcome our first keynote, Dr. Marc Williams, who joins us from Geisinger, a Pennsylvania-based integrated healthcare delivery system with 1.4 million unique patient visits each year and 500,000 health plan members. Dr. Williams is the Director Emeritus of the Department of Genomic Health, where his research in precision medicine is grounded in real-world medical practice, giving it a very practical and actionable insights. Dr. Williams will be speaking to us today about his work to develop new approaches to the diagnosis of rare genetic conditions that better incorporate existing genomic information, supporting real-time genetic diagnoses in the course of usual care. Take it away, Dr. Williams.
Thank you very much. Are the slides showing appropriately?
Yep, we can see the slides.
Fantastic. Well, it's a great pleasure for me to be here and leading off your conference today. I think it's a very exciting time, and I hope I'll be able to convey at least some of that in my initial talk. The Odyssey by Homer begins, "I wish you well, however you do it, but if you only knew in your own heart how many hardships you were fated to undergo." This really resonates, I think, for a large number of patients in our healthcare delivery system who are dealing with the issues of the Diagnostic Odyssey. And this relates to genetic conditions primarily, although they're not exclusively genetic. But for the purposes of this talk, we'll focus on rare genetic conditions that are individually rare, but are collectively very common and are estimated to affect between 2 and 10% of the population. These conditions occur across all medical specialties, but we know that the diagnostic genetic tests are being underutilized to make these definitive diagnoses that will ultimately improve our ability to care for individuals. And there's a number of reasons for this. Lack of clinician knowledge. I can recall, and I think most physicians can recall seeing an unusual patient on rounds and being told, well, you'll never see another one of those. The unfortunate reality is that we'll be seeing plenty of these, but we probably won't recognize them because we're not thinking about it. We also have uncertainties around how tests are available, what tests should be ordered, how to order it, how to interpret the results. There's a limited number of specialists available, which means access to specialists that could potentially provide care are a problem, and test reimbursement is also a barrier. Each one of these is probably worthy of a talk on its own, but I wanted to take a little bit of a different approach here. And you're probably wondering to yourself, well, why are you showing me a picture of a fractal? And the reason for this is that most keynote talks really are supposed to focus on high-level issues and sort of set the stage. But as I thought about approaching this, I wanted to really ground this into a realistic, real-world example of work that we've been leading here that does in fact reflect all of the big picture issues that we're dealing with. So the nature of a fractal is you can actually get all the information about the big picture from a little picture. So I'm hoping that my focus on our little picture will in fact enlighten you regarding the large picture of precision medicine that we're trying to color in. So we're starting with a couple of hypotheses. The first is that genetic conditions, as mentioned, are collectively common, and that if we were somehow able to do diagnostic evaluations in real time, we would more rapidly proceed to condition-specific care, much more so than in current practice. And we also hypothesize that phenotypes, or the clinical features of conditions, which would include physical examination features, family history, laboratory studies, imaging studies, etc., plus the genotypes, plus intelligent use of informatics tools, could eliminate this unnecessary delay and the unnecessary number of clinician visits that would allow us to actually make a diagnosis. So this is really dependent on imagining a future state. And this future state has several different characteristics, one of which is that everyone will have a genomic sequence available. And this is now becoming somewhat realistic because sequencing is, as a commodity, is becoming very affordable. And so it may not be too much longer where this idea that we could all have our sequence available would be a possibility. We also have demonstrated that we can extract clinical information from electronic health records in at least a semi-automated fashion, and that we can store that and make it available to at least an individual healthcare system. We hopefully will be envisioning a time when interoperability will lower barriers to communication of structured information across systems. Right now, that is there are a lot of barriers to that, but again, we're imagining this future state, that there will be resources available for automated or at least semi-automated curation of sequence variations so that the time intensivity of manual curation can be reduced, and that we would have clinical decision support that will be directed at clinicians, providers, and perhaps even patients that can support evidence-based best practices. So that's our scenario. And so we constructed this future state and put in a proposal to the first round of the Genomic Medicine Awards of the National Human Genome Research Institute, and were awarded an R01 for 5 years to really examine the components that could potentially be realized if we had this future state available to us. This project was focused around 3 specific aims. One is development of a high-impact phenotype identification system. The second is development of a dynamic virtual gene panel for real-time genetic diagnosis. And the third is analysis of clinical workflows for optimal point-of-care integration of real-time genetic diagnosis. We're going to be examining each of these 3 aims, and we're going to spend most of our time during the talk today on aim 3. And I think it'll be of particular interest to this audience because one of the things that we've done in our research is to really focus on implementation. And what we found is that there are tools available from the business world that can be purposed within the context of these medical systems to help us to learn more quickly and develop systems that are more relevant and can be implemented more readily in clinical care. So the advantage, I think, of this presentation being given to this audience is that some of the things that I'm going to introduce that I need to spend a lot of time talking about with my physician colleagues are ones that you're likely familiar with already. So this is a diagram of what we're doing here, and hopefully you'll be able to see my cursor here. But what we're looking at is concurrent analysis of transactional EHR and other clinical data. So this is data that is being entered by clinicians or the system in real time to support patient care. And we want to be able to extract key pieces of clinical information that say to us, this is potentially a genetic condition. And if we identify one of those phenotypes, then we want to ask a second question. Do we have a sequence available on this individual? And if the answer to that is yes, we want to perform an in silico analysis, really a computerized genetic test of that sequence that uses a virtual gene panel of pertinence to the phenotype of interest to be able to identify whether or not there are causal variants. Now, we recognize that not everyone would have a sequence available, so an alternative to this would be to present to the clinician information to say, we think that this individual may have a genetic condition. We would recommend genetic testing, and here is the specific genetic test that we think you should use. However, we get to this point, if we do find causal variants, then we want to present that information to the clinician with information associated with it, clinical decision support, to do confirmatory testing, and to begin to initiate condition-specific treatment. If, in fact, we do not find a variant, then what we would do is recommend usual care But we would also then take advantage of the fact that our knowledge about sequence changes and is changing rapidly. So we want to set up an opportunity where we can do reanalysis in the future that would allow us to iterate. And hopefully, if we don't find a diagnosis the first time around, the second, third, fourth reanalysis would yield a relevant diagnosis. So let's look at each of these systems at a high level. We proposed this project as a pre-implementation project, and this was based on years of experience with doing electronic health records research, which basically led to the conclusion that to get all the permissions that would be required to do this project in a real EHR environment would have taken us the entire 5 years and a substantial chunk of the $5 million without generating any useful science. So what we've elected to do is to do this in a simulated electronic health record environment that is a certified electronic health record that mimics true EHR environments, but can be done without all the required permissions. And so that's our sandbox, as you will. And we're able to load into that actual clinical notes, laboratory tests, imaging reports, et cetera, that we can run through a phenotype builder and extract terms that are standardized. And the HPO stands for the Human Phenotype Ontology, which is a curated set of terms that are used to underlie a lot of the resources that we would want to use to be able to identify specific genetic disorders. Within these data, we also have structured data from diagnostic codes such as ICD-10, laboratory values, medications, et cetera. So a combination of the structured data plus extracted data from terminology searches and natural language processing really powers this high-impact phenotype identification system, which the output of which can either go directly to a gene panel analysis if we identify a phenotype of interest, or to generate a dialogue to the clinician to order a genetic test. In the proposal, we put forward several possible phenotypes. We looked at neurologic phenotypes, things like pediatric epilepsy, early onset stroke, pediatric hypotonia. The genetic burden of these conditions is very high, so they make them good candidates for this type of an approach. We had the same situation in nephrology, where recent scholarship has demonstrated a very high genetic burden in chronic kidney disease patients. And so we thought we could take advantage of that. We also looked at cardiology and endocrinology. An interesting a variation on a theme here is that type 2 diabetes, which of course is a very common condition and does not have any distinguishing phenotypic features. We know that about 2% of these individuals have a genetic form of type 2 diabetes called monogenic diabetes or maturity onset diabetes of the young. And so this was a different sort of a use case that would allow us to assume a different type of phenotyping approach. And for the purposes of this talk and our initial study, we actually focused on kidney conditions, more from a convenience perspective, in that we had a nephrology group here at Geisinger that was already actively involved in this area, and so it would allow us to move forward more quickly. So we took advantage of some prototype software that were developed by our nephrology informaticists, and we are beginning to utilize another standard phenotyping tool called PhenoPackets, which is developed through the Global Alliance for Genomic Health standard, which is being extended to Fast Healthcare Interoperability Resources, or FHIR. And we're looking to use generalizable standards. So there are some EHR data standards called Odyssey OMOP that are being implemented. We have tools like ICD-10, which are already in broad use, the Human Phenotype Ontology, and a toolkit called Monarch. And the guiding principle is that we don't want to have to invent anything new. We want to take advantage of things that are currently available and are currently being utilized in actual clinically available electronic health records, because that is going to allow us to be able to move this into production environments much more quickly. So even though we're using this logic of sandbox, we're hoping that as these things develop, we would be able to move them into developmental environments of commercially available electronic health record systems such as Epic and Cerner. Now, the second aim, we're not going to spend much time on during the talk today, but it's really about dynamic virtual gene panels. So if we think about a sequence, whether it be an exome sequence or a genome sequence, we're talking roughly 20,000 genes, but not all of these genes are directly related to the phenotype of interest. And so what we want to be able to do is to take available knowledge about what genes are associated with the given disease of interest and only analyze those genes rather than the entire genome to be able to identify potential variants of interest. And so this is the concept behind a dynamic virtual gene panel. And so there's, again, a couple of different ways where we could potentially do this. One is that we could have a button in the EHR where clinician says, gosh, I wonder if this could be a genetic condition. They could click this button to launch this virtual gene panel, and that would prompt them to enter phenotype information manually. By the same token, we could launch this through our high-impact phenotype system from AIM-1 to essentially do an analysis of these dynamic virtual gene panels, and then would present user dialogue to the clinician if a pathogenic or likely pathogenic variant were identified. So we have, again, available information that we can use to demonstrate these dynamic gene panels. Monarch has genes associated with given phenotypes. We have commercial laboratories that do gene panels for different conditions that we can utilize. And then there are gene disease assertions from the Clinical Genome Resource, or ClinGen, another NHGRI funded project. And then we also have the ability to do some automated variant interpretation using variant effect predictors. There are a number of Geisinger pipelines that are available. There are commercially available products. There's one of our team members has a tool called Exomizer that allows us to do variant prediction, but we can also use resources like ClinVar to identify pathogenic or likely pathogenic variants that have been deposited into a annotated resource. So we have different ways that we can use to select these variants of interest. Now, here's where we're going to spend the majority of the remainder of the talk, which is the clinical workflows. And clinical workflow is critically important in terms of a successful implementation. And one of the failures that we've had, I think, in precision medicine, to be blunt, is that we tend to arrive at clinicians' doorsteps saying, hey, we're from the precision medicine group and we're here to help you. We've got this great solution for this problem that you have. And it's a problem that they generally haven't recognized that they have, and a solution that they really weren't looking for. And then we wonder, well, why aren't they using it? And so we wanted to take a different approach, which is a user-centered approach, where we present to our clinician users, what are the genetic conditions you're encountering in practice? What are the problems that you're struggling with in terms of diagnosing that? How are you able to do testing? What sort of problems are doing? So this is an afferent loop of interviews. And so we get this information, we synthesize it, and then we present it back to the providers and say, you know, did we capture the information? Did we capture what you told us? What are we missing? What are things that now, based on this reflection and this synthesis, you think we should add on? And we can iterate in this until we get something that we think really represents an accurate definition of workflow. And then we can use that to begin to develop prototypes that were embedded within the workflow that we can actually have clinicians react to in this simulated EHR environment. That we hope will identify generalizable principles so that even if we're developing it for a group of disorders that are relevant to nephrologists, it could be ultimately then applied more quickly to neurology and endocrinology and cardiology as we move this forward. So to do this, we're embarked on several aspects of design thinking, and this is where I think this audience is going to be on much more solid ground than clinician audiences, because this is frankly something that hasn't been used a lot in medical research. And so this has been a fun thing for me to experience and work with, and I think it's been incredibly valuable. So design thinking is really a creative process for problem solving, and human-centered design is done with the intent of developing viable and feasible innovations that actually meet client needs and desires. So we actually are listening to our end user, and it allows us a mechanism by which we can learn and iterate more quickly. So we want to emphasize desirability. In other words, we're solving problems that real world clinicians are experiencing, but we want to do it in such a way that it's viable and feasible, because that will enhance implementation. So the process itself is framing the question, gathering inspiration, which is understanding what people need to solve the problem they're experiencing, an opportunity to generate ideas. So we don't come with the idea, oh, you know, if we just created an alert in the electronic health record, even though we know clinicians hate alerts, that will solve the problem. Well, it almost never solves the problem. We need to think about creative ways to move past these solutions that have really not led to effective innovation. We can then use these things to generate prototypes and put them into a test environment so that people can interact and say, oh, I thought that was going to work, but if we actually put it into an environment it doesn't, we should really tweak it to do this rather than that. So framing the question, we didn't want to start from a blank slate. We wanted to say, what do we experience in clinical care that would sort of emphasize the importance of this issue? So in our proposal, we actually looked at pediatric epilepsy, because we know that a lot of pediatric epilepsy is being generated by genetic conditions. And so what we wanted to do was create these longitudinal case examples of looking at, from the time of an initial event, in this case, a seizure, the first seizure, how long did it actually take us to make this real diagnosis, and what happened in between? And so this is an example for an individual patient where at 1 year and a couple of months, this individual experienced their first seizure, and in the course of time, a diagnosis was ultimately arrived at nearly 3 years later, 2.5 years later. But look at all the things that happened in the meantime. There were primary care visits, there were specialist visits, there was an inpatient, or there was an emergency room visit with a hospitalization, there were emergency room visits without a hospitalization. Excuse me. So a lot of utilization occurred, and yet it took us nearly 3 years to make a diagnosis. And we looked at multiple examples of this. And across 20 patients where we had an established genetic diagnosis, we found that in the Geisinger data, the mean time from the first seizure to diagnosis was a mean of 3.5 years, with a range of 2 to 12 years. And what was most concerning to us is that half of these individuals received a medication that would have been contraindicated had we made the diagnosis. And 20% of these received that medication for over a year. And what I mean by contraindicated is that either the medication would be known to be ineffective, or actually had the potential to worsen seizures based on the underlying mechanism. The diagram that I showed you reflected the experience of that individual with Geisinger, but more than half of them had also been seen at a major referral center. So we weren't able to really capture all of the interventions that occurred there. 30% of them received more than one head MRI, even though we know the contribution of brain imaging to diagnosis it is valuable in less than 5% of situations. So this allows us to quantify why we think this is an important problem. So as we think then about design, we have to think about, again, setting that stage. So again, we made it clear, we have sequence available for use. So that's an underlying assumption. We have structured ways to represent phenotypes. We have an EHR that we can use to deliver information. And so we have the potential to deliver the right information at the right time, in real time, to the right person, the clinician, in the right format, through the right channel. So for those of you that are familiar with informatics, recognize that these are the 5 rights of an information system. And we need to define what information needs to go to whom, when, and how. So we started with a systematic review of clinical decision support tools for genomic medicine, but we were interested only in implemented clinical decision support tools. There's a lot of things out there that were in research or prototypes or whatever, but we really wanted to see the results of real-world implementation. And again, because we were focusing initially on chronic renal disease, chronic kidney disease, we then set up semi-structured interviews with nephrologists from Geisinger and other systems across the country, focused on genetic conditions that they encounter, how they make a diagnosis, their experience with genetic testing, and the problems that they've encountered. And then we used that information to organize information into 2 different conceptual frameworks, a system blueprint and a process map. And again, hopefully you've had some familiar with the use of those. And then we use the system blueprint, the process maps, and the rest of this information to inform our design thinking exercise. So I'm going to kind of move through this at a relatively high level and relatively quickly to bring you up to date in terms of our experience with the project. So our systematic review identified several themes. One is compatibility, and that standards or lack thereof are really recognized as being needed for this field. We noted again that alerts, while frequently used, are concerning to clinicians because they don't necessarily know from what information sources they derive, and so they need to be able to know that they trust the information, and they have to be able to understand the source of the information. We found that physician champions are correlated with a higher uptake of tools within their departments, and that if you actually develop educational tools both for patients and for providers, that will improve utilization. We have a Goldilocks problem with alerts. Some clinicians said alerts are too general and they don't show what's behind the alert. Other times they say alerts have too much information and thus make them burdensome for clinicians and patients. And the timing issue. Alerts are not being presented at the appropriate time. So we need to have this issue of how do we get it just right. There's obviously familiarity with technology. If you're familiar with the technology versus uncomfortable with technology, education support staff can be helpful, but, we're still dealing with clinicians that say, well, I'll go paperless when the restroom goes paperless, so we have to recognize the fact that not everybody's quite ready. And then we have to support workflow. How do we gain attention of providers within the workflows? When alerts pop up, a lot of clinicians just click through them because it's not presented at a time in the workflow where they're ready to consider those things. So all of that has to be considered. So we wanted to look at this through the lens of service blueprints and process mapping. And service blueprints generally are a high-level view. They're low power. They provide a wide field of vision, but they have a lot of information about context and structures, even though they're less detailed. Process maps, on the other hand, really drill down to help us to understand in much more detail about a specific process in a specific location or context, and it gives us much more information about the variation. What was interesting in our review of the application of these in medicine is that people tended to use one or the other, whereas as we looked at this, we said, boy, it makes way more sense to kind of use these together because they're going to provide different content and information that we can use as we develop our prototypes. So service blueprints illustrate relationships between different service components that are tied to the user experience, and they identify areas of opportunity to innovate and improve service delivery. Those of you who have done service blueprinting will recognize this. We are not going to go through this in painful detail, but I do want to note that in the nephrology context here, we, on the top line here, look at different aspects of the process: referral to nephrology, the examination, the treatment, and then the genetic specific aspects, seeking genetic information, receiving the results, sharing results with the patients, and treatment. And then down the side, we have clinician actions, the front of stage interactions, the things that are occurring in that interface with the clinician and the patient, things that have to happen behind the scenes to allow the clinician to be able to provide information to the patient, and of course the support processes like electronic health record systems and laboratory information systems, et cetera. And that creates these so-called swim lanes that we analyze. What's interesting at a high level here is note that we don't have any of the stars or diamonds in this area. These are processes that are very familiar to the nephrologist, and they don't identify problems or barriers here. But once we move into the genetic testing area, we see multiple barriers appearing. That's represented by these diamonds, but also the need for potentially specialist consultation to help with interpretation. Those are the stars. So at a very high level, it tells us that we have a lot of needs identified by the nephrologist as part of this service blueprint if we're going to extend nephrology services into genetics and genomics. And now we can begin to say, well, let's explore that and figure out how those barriers actually represent themselves in different clinical contexts. And so that we're using process mapping, which is a flow chart that visually represents the sequence of events for a given action. And we developed process maps for our adult nephrologists in Geisinger, and we identified different pathways. So here's one pathway where a patient has a nephrology appointment, and some of those appointments are just follow-ups. We've resolved all issues, in which case we just have care continuity here. But there are unresolved issues. Then in this pathway, the nephrologist may do a kidney biopsy. They may do imaging or laboratory tests. They may take a family history, and that may lead to a diagnosis. And if it does, then we can begin condition-specific care. But if it doesn't lead to a diagnosis, this is where genetic testing in this pathway begins to appear. And you can see here the potential problems with handoffs. What test do I order? How do I order it within the system? Will the patient get the test? Will the patient be able to pay for the test? And then I get a result back. How do I interpret that result? How do I give the result to patients? And do I utilize or make referral to specialist care? So that's one pathway where we address these issues. But here's a second, where again, if there's an unresolved issue, this individual nephrologist or this group of nephrologists that follow this pathway will do family history biopsy, imaging, and serology, but also will make a specialty referral sort of in parallel with this. So this is a different pathway. So the service blueprint reflects this, but if we don't understand the fact that the clinical workflows are different, we can miss opportunities if we try and impose one specific way to do things. And within Geisinger, a single health system and a single department of nephrology, we found 3 different pathways for care. And we found multiple barriers, including the return of results. The individual doesn't know if they're actually receiving the result or not. The impact of insurance and reimbursement. How do I order genetic testing? There's no centralized or standardized process to this. The implications of a test result. I don't know what to do with the result or what to do with them. If we try and transition the patient to genetics, there are complications with that handoffs, and half the patients don't make it through to that referral. And then again, it's inconsistent in terms of who the individuals are referred to. So lots of different variation in care. This is unexplained clinical variability, and this does not contribute to improved outcomes. So we learned a lot three distinct processes or process maps exist for ordering genetic testing at Geisinger. The referral, examination, treatment are pretty standardized for nephrologists, but once we get into the genetic testing realm, large amounts of variability exist. There are common barriers across all three processes: lack of knowledge, lack of access, and the complexity of the process. But there are also common facilitators in the three categories. Some nephrologists have had very good user experience, and because they are ordering more genetic tests, have become comfortable with the process. In some cases, the diagnosis is very straightforward, and there are experts within the nephrology department that other colleagues can rely on. And so we also then were able to identify components of this ideal future state of genetic diagnosis. So components would include decision support, easy or easier genetic testing processes, guidance at appropriate times within the workflow on what to do with test results, creating these teams so that they can more easily access specialty care where needed, and then systematic improvements such as this idea of a genome in every chart. But there are lots of things that we don't know. While we know about these current processes, we don't know what does this intervention look like and how would we best implement it. And that's where we move into design thinking. And we incorporated our clinicians to help us with the prototype. How might we take the things that we've learned and create a prototype to implement with the goal of improving patient care by increasing genetic testing earlier in the nephrology evaluation in such a way that is desirable by clinicians. In other words, it's acceptable, it's feasible, at least in the context of Geisinger, and is viable economically. So we did this through a workshop, a design thinking workshop, where we had participants across multiple disciplines. So we had clinicians, we had informaticists, we had other disciplines, pharmacy, etc. These individuals were all ones that had at least some familiarity with the challenges involved in this process. We presented the results of the previous work just as I presented them to you. We set a design task in front of them, and we presented the final design ideas, and then had a group discussion and an analysis, and then this output will be synthesized into a prototype. So I'm just going to give you a couple of snapshots into the design thinking workshop. So we had to consider roles and responsibilities. When you have situations or scenarios, who is needed within the team to get this to work right. We had to understand the order of operations and the design of the workflows, but we had to ground the intervention to meet the needs of the current state, as well as inform a potential future state. With the recognition that we're a healthcare system, and at the end of the day, how does this benefit patient care? What are our potential risks if we're successful? If we order a lot of genetic tests, is that only going to provide benefit, or could that raise other risks? And is there anything else we need to consider? This is a screenshot of our workshop results, and I'm not going to go through this in any way, but each of our participants was asked to design, what they thought would work based on what they heard from the workshop. And so we got all sorts of interesting designs, and then these designs were presented as part of the workshop, and people were able to say what they liked, what they didn't like, if they had a favorite from the group. And then in design thinking workshops, there is a so-called decider who can ultimately say, based on all of this input, where do I think we need to go with the prototype? And what you can see from these little purple squares here is that there were different aspects of the designs that were potentially attractive, that address different areas, and that some sort of a combination or synthesis of this into a prototype may result in the best version 1 of the prototype. So it was the first time I'd really participated in this type of a design thinking workshop, and I thought it was really valuable. And the feedback from our multidisciplinary attendees was, this was really fantastic. This is exactly the way we should go about problem solving. They recognize, and this workshop was 4 hours, so we got people to commit to take 4 hours out of their busy days to do this. So it was really very rewarding. So our next steps from this are to synthesize the results and develop a prototype. That prototype will then be implemented within our EHR sandbox so that we can test the prototype with workshop participants and say, what do they like, what do they not like, what's not working, and we will do an iterative revision based on the feedback. And once we have this prototype refined with our working group, we will then have this as a version 1 workflow to present to a broader audience, because again, what works at Geisinger may require additional revisions to generalize beyond our site. And so we're going to continue this iterative revision and ultimately implement a final version in a simulated EHR environment where we can use real cases in the simulated EHR to measure how effective this will be, which we anticipate will lead to further revision. I always issue a guarantee with any of my prototypes. I say, I guarantee that this is wrong or your money back. The second part of the guarantee is that we will fix it based on your input. And so ultimately, if we're able to get to a point where we think it's really working well, then we can consider extending this into epic concern or development environments where we can, again, expand within a real commercial EHR environment, whether or not this is going to work. And we are hoping that at the end of our 5 years that this will move to an implementation. I want to thank a very large team. This is our internal team at Geisinger. We have clinical content experts. Alex Chain in particular and Gurmukh Singh from Nephrology have been extremely critical in this. Katrina Romagnoli and Zach Salvati have led the process mapping, service blueprinting, and the design thinking workshop. Darren Johnson, who's a PhD candidate that works with me, did the systematic review, and we have lots of other folks. We've also done this in a multidisciplinary team. So we have Intermountain Healthcare, another large integrated healthcare delivery system, involved in this process. The University of Utah's Department of Biomedical Informatics, Jackson Laboratory, Peter Robinson is a clinician who developed the human phenotype ontology and Exomizer, and then Gil Alterovitz is consulting on the process as he's an expert in FHIR and application of FHIR to genetic and genomic applications. Now I want to pull back out of our little tiny fractal into the big fractal, and my concluding slide is to really, at a high level, present you with some summary points and some ideas for discussion. We need to stop thinking about sequencing as a one-off test. We can't treat it like other tests. If we do a sequence, we need to figure out how to keep the data available and use it for multiple uses. That's the only way that we can really effectively integrate the idea that everyone should have a sequence available as part of healthcare will work. If we treat it as a disposable one-off, that will never work. I hope I've made a convincing case to you that this impositional model of implementation, where we come with a solution for a problem that nobody identifies as a problem, is not a viable way to move forward. We need to do more of this engagement to provide the context needed to divide tools that are really going to be useful. And we need to steal shamelessly from other disciplines like business, implementation science, quality improvement, and anything else that we think can be applied. And we need to use existing standards where possible. And if there are really situations where new standards are needed, then we need to develop them, but develop them in the context of what is needed to move this forward in the implementation space. And I think I've made the convincing case that if we don't have collaboration across multiple disciplines, that this will never be successful. So with that, I will end my formal presentation, and I'm happy to take questions.
Thank you, Dr. Williams, for that incredibly interesting presentation. We want to give our audience a little break before our next session, the Bruin Tank, which I know I personally am very excited for. So we'll see you all there.